Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm doing another Kahoot, and I'm going to be covering the integumentary system. Now, before we get started, as always, I'm going to ask you to please support me and support this channel. How can you do that? Like this video, you're going to love it. So press the like button now so you don't forget. Subscribe to my channel if you haven't done so already, and press that red notification bell so you'll be notified every single time a new video is released. Don't forget, I'm now offering next generation NCLEX review sessions and one-on-one tutoring and consultation sessions. You can reserve your spot right now by going to my website, nexusnursinginstitute.com. And while you're there, be sure to check out the audio lessons I have available. Almost daily, you can find me covering a variety of nursing topics on my other social media platforms, such as TikTok, Instagram, and Facebook. All right, guys, without any further ado, let's get started. Integumentary system. First question, which statement would indicate that your patient understands the administration of a Mantoux test? Would it be, I'll get the injection in my deltoid muscle, I should rub the area for 5 minutes to increase absorption, I'll come back to get it read in 72 hours, or if I develop a rash, the result is positive? Which one is the correct answer? Which one shows a correct understanding of the Mantoux test? What do you guys think? All right, I'll come back and get it read in 72 hours. So guys, the Mantoux test, AKA PPD test, AKA skin test, it's all the same thing, right? So what happens is after you get the test done, you have to come back in 48 to 72 hours. That is your time frame. Anything before 48 hours, it's null and void. It's not time yet. It doesn't count. And anything past that 72 hours, you have to get another test done. Something else that's important to know about the Mantoux test. When you're administering that Mantoux test, remember, guys, you're going to inject 0.1 mLs. How? Intradermally, not IM, not sub-Q, intradermally. And guess what? The bevel has to be up. That's the only way that you're going to make that bump. You're going to make that bleb or bleb, B-L-E-B, right? So that's the only way you make that bleb, with the bevel up. So that's very important to know. Your patient suspected of having head lice. Which finding would be conclusive for this diagnosis? Would it be pruritic wheals? Would it be oval white dots stuck to the hair shaft? Would it be painful and pain and redness of the scalp? Or would it be itchy papules and pustules? We're talking about head lice. What do you think the answer is? Okay, it's oval white dots stuck to the hair shaft. You guys are doing great. So the oval white dots that you're seeing, those are like the eggs of the lice, the nits. That's what you're seeing. Now let's look at the other choices. The pruritic wheals. Pruritic, that's a word for saying like itchy, right? When you have pruritus, something very itchy. Those pruritic, if you see pruritic wheals, you should be thinking of some sort of allergy. Pain and redness of the scalp, that is not a clinical manifestation of head lice. And then itchy papules and pustules. If you see itchy papules and pustules, and you see another word, this one's important, vesicles with the itchy papules and pustules, you should be thinking of scabies, right? But when we're talking about head lice, we're looking for those white oval dots stuck to the hair shaft, which is the eggs of the lice or the nits. Your patient has a skin infection and they've been prescribed Linezolid 500 milligrams by mouth 3 times a day. Which would be your priority teaching? Is it going to be to take the medication on an empty stomach? Is it to apply heat to the wound? Is it to report any diarrhea? Or is it to limit the fluid intake? What do you guys think? You guys are doing great on the live. You are absolutely correct on the live. Let's see how you're doing in the class, guys. What do you have for me? Yes. Report any diarrhea. Okay, so this type of antibiotic, that's what it is. You guys probably know it by Zyvox, right? It's easier for me to say Zyvox than the generic form. But anyway, this antibiotic, an adverse effect that you have to warn the patient about, and you have to tell them if you're experiencing the symptom, let us know right away. It's diarrhea. Why? What are we thinking when it comes to diarrhea antibiotics? Pseudomembranous colitis. You're thinking of what? C. diff. Let me give you guys a clue. Let me give you guys a hint. Let's say you had no idea what the answer was. No clue at all. You had to guess. Whenever you have no idea what the answer is and you have to guess, I want your mind to go to one of these three things. ABC, airway, breathing, circulation, right? Because you can't live without breathing, right? You can't live without oxygen. I want you to think about the nursing process, assessment, diagnosis, planning, intervention, evaluation. You have to be able to assess your patient before you can actually perform an intervention, right? And the third thing I want you to think about is Maslow's hierarchy of needs. What is most important to us? What are we going to be most concerned about when it comes to our patient? And that is physiological integrity. That is what is keeping our patients alive. So let me tell you some important things that fall under physiological integrity. I've been preaching this to you guys for a million years, but this is your first time watching. Grab a pen and write it down. Thank me later. When it comes to physiological integrity, what are we going to be concerned about? Fluid electrolytes, vital signs being out of range, labs being out of range, dehydration, diarrhea, nutrition, any signs and symptoms of an MI, a heart attack, any signs and symptoms of a stroke, seizure. Again, guys, anything that physically keeps your patient alive, hemodynamic status, all that good stuff. Yeah, you see one of those, choose it as your answer. How are you guys doing on the live? Heather, thank you for sharing the live. Okay, you guys are doing great. Let's keep going. What should be your primary nursing intervention for your patient diagnosed with Tinea corporis? Is it to administer the influenza vaccine, teach about how to prevent the spread of infection, to teach a patient about dietary restrictions, or to teach a patient how to take the antibiotics? What would be the primary nursing intervention for the patient diagnosed with Tinea corporis? That's right. Teach them about how to prevent the spread of infection. So what is Tinea corporis? That is ringworm. And to be specific, because Tinea is ringworm, corporis is on the body, right? So ringworm on the body. Ringworm is very, very, very contagious. By the way, ringworm is a fungal infection. So why would you give the patient antibiotic? This is not a bacteria. It is a fungal infection. And it's very contagious and it takes a very long time to get rid of. So you're going to teach the patient about preventing auto inoculation. You're going to teach them how to not spread the infection on their own body, because they might touch their skin over here where the fungal infection is, and then they touch their face. Guess what? Don't be surprised if you see that ring on their face. Why? Because it is very contagious. So it's very important to teach them how to prevent the spread of infection. It's not going to be teaching them about the flu vaccine, because this is not a virus. It's not the flu virus. It's not going to be teaching them about dietary restrictions. When you have Tinea corporis, you're not on dietary restrictions. Unless you're taking a medication such as Grisio, right? If you're taking Grisio, if the patient's been prescribed Grisio, you're going to teach them to eat foods that have fat. And the way you're going to remember that, Grisio, grease. So you're going to teach them to eat foods that have fat, that have grease in it, because it's that grease that actually activates the medication to help get rid of the fungal infection. But anyway, they're not going to be on dietary restrictions. You might teach them about the medication, but they're not going to be on dietary restrictions. And last, you're not going to teach them about antibiotics, because again, this is a fungal infection, not a bacterial infection. Let's keep going. Your patient's just been diagnosed with a squamous cell carcinoma of the face. Which teaching is most important to provide to your patient? Is it teaching them about surgery, teaching them about the application of antifungal cream? Is it about the administration of antibiotics, or teaching them about hospice? What is most important to teach your patient who's just been diagnosed with squamous cell carcinoma of the face? What do you guys think? Very good. Overwhelmingly, you guys got it right. You're going to teach them about surgery. Let me tell you something about this type of cancer. It's a type of skin cancer, and it metastasizes very quickly to the lymph nodes. So as soon as that patient's diagnosed, it is a very fast, very quick transition from them getting that diagnosis to them actually having surgery. So the minute they get that diagnosis, you're going to be teaching them about the upcoming surgery. You're going to be a witness to them signing the consent. Now, let me talk to you about the consent real quick. You are the witness, so you're not going to be teaching the patient about the actual surgery. And when I say the actual surgery, I'm talking about details about, what's going to happen during the surgery, what can possibly happen to them during the surgery, what can happen to them if they refuse the surgery. All of that, the surgeon's responsible. You're just going to watch and make sure that the consent was informed, and you're going to watch them sign because you're the witness, and then you're going to put the consent in the patient's chart. Now, if the patient signs and you go to put it in the chart and you realize, oh my gosh, this patient was medicated, they already got their pre-op meds before they signed, it's no longer informed consent. That surgery is going to have to be canceled until the meds wear off. They're going to have surgery the next day because they cannot sign and give their consent under any chemicals that may change their level of cognition. Okay. True or false? Tinea capitis is a fungal infection of the scalp. Is this true or is this false? What do you guys say? True or false? Yep, it's true. And here's how you remember it. Tinea capitis. Think of a hat. It goes on your head. So that type of fungal infection. Remember, I told you the word tinea means, fungal infection. So tinea capitis is fungal infection of the scalp. Very good. Which information is best to provide to a patient diagnosed with tinea capitis? Would it be not to share combs, brushes, or hats? Would it be to avoid sexual contact for 10 days during treatment? Would it be to be sure to use antibacterial soap? Or would it be to keep the area clean and dry? What do you think the correct answer is? Yep. Do not share hats, combs, hairbrushes, scarf that you put over your head, anything that you put over your head, do not share it, because all of the tinnias are what? They are very what's the word? Contagious. They're very contagious. So you're going to teach them not to share. It's not an STD, so you don't have to tell them about avoiding sexual contact for 10 days during sexual treatment. But the area where they do have that fungal infection, you better tell them not to have skin to skin so they don't give it to the person. Be sure to use antimicrobial soap. That is great, but guess what? That doesn't stop the spread of infection and keeping the area clean and dry. That is also great, but that doesn't stop the spread of infection. And again, when it comes to tinea, one of your biggest priorities is to stop the spread of infection or transmission, I should say, to stop that spread of transmission because it's so contagious. Your patient presents with a canker on his penis. The ulcer is shallow and painless. What do you suspect the diagnosis to be? Do you think it's HIV? Do you think it's chlamydia? Do you think it's syphilis? Or do you think it's gonorrhea? What do you guys say? Very good. Syphilis. Let me tell you the two words when you see syphilis needs to come to your mind. That word canker and painless. When the patient has a painless canker, syphilis needs to come to the forefront of your brain. When it comes to syphilis, if the patient's infected with syphilis, they have to be on high dose antibiotics. To be specific, they're going to get, oh my gosh, I'm having a brain fart. Guys, tell me on the live, what's the antibiotics? I'm penicillin. Oh my gosh. I'm sorry. I was having a brain fart. They're going to be on high dose penicillin. Let me tell you something. If the patient has syphilis and it goes untreated, syphilis will eventually kill them unless another comorbidity kills them first. Okay. And that's very sad because syphilis can be treated with a antibiotic that costs $2.99 at Publix, right? So it's very important for the patient to be tested and to be treated immediately if they test positive for syphilis. You guys are so smart. What would be your priority assessment for your patient during the first 48 hours following a major burn injury? Would it be hyponatremia and hypokalemia, hyponatremia and hyperkalemia, hypernatremia and hypokalemia, or hypernatremia and hyperkalemia? What do you guys think? Someone said that's how Al Capone died. Did he really die from syphilis? All right, let's focus. So, guys, the correct answer is hyponatremia, hyperkalemia. Let's talk about burns because you guys need to have an understanding of burns. So, patient has a major burn, right? Now, when they have a major burn, one of the things that happens is all of the fluid that was in the blood that was in the vascular space, gone. It goes out into the tissues, and that's why that patient will swell up like a balloon. They look so swollen, and you're thinking, okay, well, they're swollen. They got a whole bunch of fluid. How can they be dehydrated? Because we're always talking about what? Within the vascular space. All of the fluids, all of the electrolytes is where in the tissues and not in the vascular space where it needs to be. So what happens is that fluid goes in the vascular space. And what's in this fluid? We have blood, we have sodium, right? So the patient becomes hyponatremic because all the sodium leaves the vessel and it goes, oh, my battery's low on my phone, and leaves the vessel and it goes into the tissues, right? And the potassium that was in the cells leave the cells and goes into the vascular space. Remember, sodium and potassium, they have an inverse relationship. So the sodium is low. We're seeing hyponatremia because all of the sodium that's in the fluid has left the vascular space and it goes to tissue. And meanwhile, the potassium that's in the cells leave the cells and they come into the vascular space. So we're seeing hyponatremia and hyperkalemia. That is very important to know, guys. Let's see if I can get this done before my phone dies. All right, which is the fluid of choice for burn patients? With what I just explained to you, what do you think is going to be the fluid of choice? Do you think it's going to be albumin? Do you think it's going to be 5% dextrose in water? Do you think it's going to be lactate ringers or half normal saline? What do you think the correct answer is? Very good, lactate ringers. That patient with a major burn and we have all this fluid going on to the interstitial space, we're going to want to give them what? An isotonic solution. You're going to want to give them lactate ringers. You see albumin? Albumin is a great addition. It's a great supportive therapy because albumin, the part of the blood that's protein is albumin, right? Okay. Follow me. Guess what helps keep the fluid in the vascular space and it prevents it from leaving and going out to the tissues? That protein part of the blood, right? So albumin is great because albumin is going to help keep the fluid in the tissues. That's wonderful, but that's not going to be our primary fluid. Our goal in that patient that had a major burn is getting fluid in them within that vascular space very quickly. So we're going to give them lactate ringers because it's going to go in the vascular space and it's going to stay there. But albumin is a great supportive therapy, just not the primary that we give. 5% dextrose in water. Are you trying to give that patient hyperglycemia? Let me tell you something. That first 24 hours, if you give that patient that 5% dextrose, you may cause them to be hyperglycemic. You may end up having to give them that dextrose later when you're giving, insulin, potassium, and that's another. I can't even get into that because it's going to take a while. But the point is, the first 24 hours, you're not going to be giving them glucose. If you have questions about that, by the way, I did a teaching on burns and I went over the time frames of when you're going to give the lactate ringers, when you expect to be giving potassium, insulin, glucose, all of that. You can go to my YouTube channel to watch that video if you have any questions about that. Anyway, moving on, half normal saline and 20 milliequivalents of potassium. Why would you do that? I just told you when the patient has a major burn, they have hyponatremia and hyperkalemia. The potassium's already high. Remember, potassium has a therapeutic range of 3.5 to 5. Why in the world, if they're hyperkalemic, we go ahead and give them more potassium? Are you trying to throw them into a dysrhythmia? Absolutely not. We're not killers over here, so we're not going to do that. We're going to give our patient lactated ringers. Your patient has a reddened sacral area that is unrelieved by changing her position. Which interventions will you begin? Are you going to edit the care plan to increase the frequency of turning the patient? Are you going to massage the reddened area to relieve that pressure? Are you going to place a pillow on the reddened area to relieve any of the pain? Or are you going to use antibiotic soap and hot water to cleanse the sacral area? What are you going to do? Ashley says she's going to yell. Ashley, I can yell at you guys, but you can't yell at the patient. All right, guys, the correct answer is to edit the care plan so that you increase the frequency of turning the patient. Now, if you see a reddened area that does not blanch, but it's still intact, we're talking about a stage 1. This patient has a stage 1 pressure ulcer. Keyword pressure. So we have to increase the frequency of turning that patient so there's not too much pressure for too long on the sacral area, because what we don't want to happen is for it to turn into a stage 2. Now, while we're talking about care plans, let me make this clear. For testing purposes, guys, I'm not talking about the real world, because the real world and testing world are two different things. So for testing purposes, the only person that is allowed to change, to edit, to update the care plan is the registered nurse. The LPN and the LVN, they follow the care plan, but they do not change the care plan at all. All right. Oh, let's look at the wrong choices. Look at massage the reddened area. If the patient's having a pressure ulcer because of pressure, why would you massage and put more pressure on that area? It makes no sense. Placing a pillow on the reddened area to relieve any pain. You need to do what? Change the patient's position so there is no pressure on that area. And using antibiotic soap, cleansing area, great, but that's not going to do anything for the pressure. But look at the rest. Look at what it says. Hot water. Do we use hot water on patients? No. Are you trying to burn the patient? Absolutely not. So the correct answer is increase the frequency and turning the patient. Who's at the highest risk for impaired wound healing after having a surgical procedure? Would it be an adult male with hypertension? Would it be an adult woman with migraines? Would it be an older adult without any comorbidities? Or would it be an older adult that is diabetic? Who do you think is going to be at highest risk for impaired wound healing after having a surgical procedure? Okay, guys, and the correct answer is a diabetic patient. Diabetes causes poor wound healing. Think about it. Bacteria and pathogens, they love moist, dark, wet, sugary environments. That's where they thrive. That's where they multiply. That's where they reproduce. They love that type of environment. So that patient who's diabetic, it's going to take them a lot longer to heal. They're going to have poor wound healing. You're teaching your patient about how to prevent the development of basal cell carcinoma. Which teaching do you think is going to be priority? Is it to avoid skin dryness? Is it to avoid sun exposure? Is it to avoid antiviral agents? Or would you say it's to avoid exposure to radiation? We're talking about basal cell carcinoma. What do you guys think? That's right, the sun. The sun is the most common cause of basal cell carcinoma. So you're going to teach the patient about not only avoiding sun exposure, but also what? Tanning booths. Yeah, those tanning beds. Stay away. Okay, guys, we're down to our last question. What is the number one way to prevent the transmission of infection? Is it to wear gloves? Is it hand hygiene? Is it to quickly remove soiled dressings, or is it to give antibiotics? What is the number one way to prevent the transmission of infection? Thank you. Sky said everybody better get this right. Okay, almost everybody got this right. Hand hygiene. Washing your hands, that is the number one way to prevent the transmission of infection. If you're in the nursing program now, or you're about to start the nursing program, so your first semester when you're going over the basics, fundamentals of nursing, you better bet your bottom dollar this is going to be a test question.